cardiac surgeon and honorary senior lecturer at Birmingham Children's Hospital. He's also co-director of the CLS program, and is also a member of the steering committee of EUROELSO, and very much involved on a medical education and national level. So he is going to talk about the failing gland and fontan circulation, difficult scenario to deal with. So over to you, Tim.
Well, thank you very much, Judith. And it's a great pleasure to be able to give this talk today. Now, I've got no disclosures for this talk apart from one thing. If we talk about the failing glen and the failing fontan, this is what we're dealing with. It's a huge area. My talk is going to cover probably even just the very, very tip of this iceberg that we can see. But in reality, and what we're dealing with every day in managing these circulations is this. And in fact, the failing fontan is the focus of one day, in fact, 3-day conferences in itself. So I'll try and give you an overview, really, and relate it to ECMO for the purposes of this conference. And what we're going to do is we're going to talk a little bit about the glen, or cave pulmonary circulation, the fontan, or the TCPC. We'll talk about circulatory failure, reasons why and how to recognize it, and then what our therapeutic options are. And we're going to be drawing in a little bit of ECMO on that. So let's first of all talk about the glen circulation. 1958, and here's Glenn, who initially described this quite an anatomically destructive situation, where initially he put the RPA, he divided and put it end side into the SVC, ligating the SVC and the proximal RPA here. Now, subsequently, the SVC and RPA were put end to end, so we had a SVC flow to the right lung. Subsequent reiterations of this with a hemifontan, where obviously the SVC was connected with the wide open communication to the pulmonary arteries and with an obstructive baffle put in the mid part of the right atrium. And now what I think we're all familiar with is what we call the bidirectional modified glen, or cavopulmonary shunt. Much more anatomically preservative operation, with the SVC divided and joined end to end to the PAs. And why do we do a glen procedure? Well, we want to obviously increase pulmonary blood flow. It's another source of pulmonary blood flow, and it sets up the platform for single ventricle circulation. In putting the SVC into the PA architecture, we decrease the volume loading in the heart. So we take the heart down the Starling curve with a decrease in preload. We also preserve PA architecture, which is important. I'll come on to that. And ultimately, the goal is, of course, to provide pulmonary blood flow without a subpulmonary ventricle. So in normal circulation, blood is pumped into the lungs, but here, blood flows passively. And I'll come back to that in a minute, because that's one of the cruxes as to why this circuit can fail. The Fontan operation, here we see Monsieur Fontan, the operation 1971 for the management of tricuspid atresia. And you can see here what he's done is the glen operation with the SVC end to end to a right pulmonary artery. And then he's done what's called an AP Fontan. He's joined the atria into the pulmonary arteries, closing off the ASD, and of course tricuspid atresia. This then is just a direct flow into the left lung. So that was the initial Fontan operation. Mark Laval and his group at Great Ormond Street, when Mark Villig was working with him, then set up this concept of the total cavopulmonary connection. And what they described was really a lateral tunnel Fontan. And this is an endoside anastomosis to the SVC, to the pulmonary artery, creating a baffle with inside the heart. Now, people often get confused about these different operations. They all achieve the same thing. The lateral tunnel Fontan, which was Mark Laval's major step forward of total cavopulmonary connection there, with a baffle inside the heart and a small fenestration. The completed hemifontan, remember from the previous operation, we had the previous slides, we had the SVC joined into the pulmonary arteries, and then we can use and tunnel the IVC then through into that join up. What I think we've all moved to these days, though, is predominantly the extracardiac fenestrated Fontan, usually placing a Gore-Tex tube in this part of the circulation. If I look at our own practice in Birmingham, pretty much 1,000 Fontan operations completed now. Around about the year 2000, green being the extracardiac fenestrated Fontan with a Gore-Tex tube is our predominant operation of choice now. And we've gone over to that because of the decreased incidence of thrombosis, dysrhythmias, and a better long-term functionability, and so less key indicators of Fontan failure. But it still does exist, because ultimately the Fontan is not a normal circulation, and we'll come on to that. Now, if we're going to talk about failure of any intervention, people often think, oh gosh, and they start telling you all these different ideas and answers and concepts. The easy way to look at it is there's acute failure and there's chronic failure. And these are the two titles you should very much think of when you're looking at the single ventricle circulation. And either acute or chronic failure can be due to an anatomical problem, a hemodynamic problem, or a physiological problem. And if you break it down to these simple ways, it's much easier to analyze what's going on. Let's go back to the Glenn or cavopulmonary circulation. It's a passive blood flow. So in order for this circulation to work, the SVC pressure needs to be greater than the pulmonary artery pressure. I'm going to say the opposite of that. The pulmonary artery pressure has to be low and lower than SVC pressure, because that's what drives the Fontan, is that pressure gradient from an SVC pressure to a low PA pressure. And obviously, downstream of that, we have to have a low end diastolic pressure. Otherwise, that will transmit retrograde back into the pulmonary arteries, and you won't have forward flow because it's a passive circulation. And we want to reduce the resistance, and so we need good-sized pulmonary arteries. Now, the indications then for doing a cavopulmonary shunt are to meet these criteria. We say greater than 3 months of age. And the reason we say that is because your pulmonary artery pressure, which is the same as systemic pressure at birth, takes up to 3 months to come down to its low level so that the circulation will work. It's why we do a BT shunt in the neonatal period to overcome that high PA pressure. But we let 3 months of age, the pressure comes down. And the child to get to in excess of 4 kilograms is what we've always said, because then we think that's a time when the PAs are of good size. We've gone back and looked in our own series. We looked at about 300 patients who had undergone surgery, modified Norwood for hypoplastic left heart syndrome, so pure hypoplastic left heart syndrome, not the tricuspid atresia population, because we wanted to really look on the effect of age and weight on outcome, and also planned versus unplanned timing of the Fontan. Now, interestingly, what we found was that looking at transplant-free survival over a period of time after the Glenn procedure, we found that planned versus unplanned did reach significance in that you had a greater outcome if you had a planned operation, but it wasn't as big as we thought it was going to be. And in fact, age and weight themselves were non-significant indicators of survival or transplant-free survival. And somatic growth was more important. So meaning if you're growing well, if you're thriving, even if you're ahead of 3 months age, you'll probably do well with a Glenn. What we did find, though, was the two strongest indicators of transplantational death, so circuit failure, were need for repair of the common AV valve, and this in the setting of, remember, right-dependent circulation, and also ventricular function. So the biggest indicators of doing badly with the circuit failure afterwards are poor AV valve function going into the operation, needing repair, and poor ventricular function. So that's quite important, really, and that's quite an important statement moving forward. So you can do it early if the child's thriving with good function, no AV valve regurgitation. Let's look at acute failure now. Acute failure of the Glenn circulation. Well, what we're normally looking at is failure to saturate with a high pulmonary artery or high Glenn circuit pressure. And what we'd say is a pulmonary artery pressure in excess of 18 millimeters of mercury once you've done the Glenn. A TPG really looking in the excess of 6 or so, 6 to 8, and obviously desaturating means the child is really in some problems. Now you've got to exclude the immediate causes of that, such as pneumothorax and maybe resistance pulmonary hypertension, but actually once you treat all those, if you're still failing, there's a problem. We'll have unloaded the ventricle, as I say, moved it back down the Starling curve, so there'll normally be low cardiac output in association with this failure, so a difficult circulation, a swollen head and face on the child. Now the options here really, the only option, you can try and manipulate the pulmonary artery pressure with vasodilators, but it's not usually that successful. You've got to exclude any obstruction in the circuit, such as at the atrial septal level. aortic arch, which the ventricle will be very susceptible to. Make sure the pulmonary artery pressure, you've done all you can to keep it low, and make sure there's good pulmonary venous drainage and you haven't got significant avalvular regurgitation. The option then really is take down of the cavopulmonary shunt. Trying to tough it out usually makes the situation worse. Going on to ECMO is a real problem, because if you go on to ECMO, and sometimes you have to, you're unlikely to wean from ECMO with that cavopulmonary shunt, because you'd only add to the burden of pulmonary artery hypertension. And so really the only option for ECMO is to ECMO as a sort of a salvage type procedure, or to stabilize the situation, to go back to the operating room, reverse the CP shunt, put them back onto an arterial shunt or an RVPA conduit, then recover the patient. You can normally wean off ECMO then, and then reassess and treat if there's anything to be treated. Chronic failure, well, this is really the child who fails to get out of hospital, fails to come off oxygen, persistent low cardiac output over a period of time. Yes, optimize the circulation, again, remove all anatomical barriers, use pulmonary vasodilators, assess whether they're actually having any benefit, and then your option then really is transplantation. And I would only really go for ECMO, because this would be a bridge to transplantation in this group, and that is only done once we have confirmation from a transplant centre that they would list the patient, and that they would list the patient and convert the patient on ECMO. And that's quite a big ask, because it does add hugely to the risk, particularly in a small child who's unlikely to get an organ, certainly in the United Kingdom. So let's now look at the Fontan circulations. The survival post-Fontan, we see these great graphs, 94% survival if you take the people pre-op Fontans and what's their long-term survival out to 5 years. But we know their functionability does deteriorate, and beyond that, their functionability is deteriorating with problems. In the 1980s, we had the 10 commandments for the successful Fontan. I won't go through them all, but they pretty much were unobstructed pathways with a generous connection, low pulmonary artery pressure, and adequate ventricular function. Those were the sort of highlights. And we produced this paper in 2007, Simon McGurk on behalf of our group, where really we said there were basically 2 commandments for a good Fontan, and that was low pulmonary artery pressures with unimpeded pulmonary circulation and good ventricular function. And those are the 2 things you're really looking for preoperatively. Now, as I say, Fontan failure is the focus of entire life's work for people, and particularly cardiologists spend a lot of time focusing on this. Let's look at early failure. Again, early failure, low cardiac output. This is a very good article, and I'd suggest you all, if you're interested in this area, read this article. It's a lovely summary of Fontan failure and management of the Fontan circuit. Early failure, low cardiac output, pleural effusions, parathoraces, ascites. Well, then you're really going to have to think about reversing that Fontan if you can't deal with any other issues. And the late failure, well, here we've got really signs of systemic and physiological burden of high venous pressure from a Fontan circulation. And whilst we can manage those things, as they progress, we then are looking to transplantation. What is the management of the acute failure? Well, again, exclude the mechanical causes. Now, I put septum here in bold because often that's missed at this stage. And with the extracardiac fenestrated Fontan, the septum can be pulled down into the circuit. The roof of the atrium can be pulled down, restricting a septum. Similarly, the tube can press back on the veins. And you need to make sure you haven't created a mechanical problem. Optimize the pulmonary vasculature with vasodilators, but if it doesn't work, you're going to have to take down to the CP shunt and then reassess. The problem if you go on to ECMO is a surgical takedown on ECMO to a CP shunt. You're then left with all the problems of a CP shunt, having undergone 2 repeat operations, high pulmonary artery pressure, you're unlikely to come off. And I'll suggest an alternative to surgical takedown as my final slide. Chronic failure. This is really the domain of the cardiologist, the paediatric, and particularly the adult congenital cardiologist. We can't go into it all now, but it is optimal medical management and then considering transplantation and really whether the patient's suitable for transplantation. To support a patient on ECMO for transplantation with a Fontan puts them in the highest risk group of all, with a 30% mortality really at 1 year and in excess of a Fontan undergoing transplantation. Transplantation of a Fontan on ECMO puts them at incredibly high risk. So finally, just to mention, this is a case, we've done this a number of times now, for takedown of the Fontan, a 4-year-old who developed ARDS. and then we ended up putting them on ECMO. They're really in extremis. The only way we thought we could get them off was to take down. And so what we did is we actually took them to the catheter lab and did what we call a catheter takedown. This is our preference now rather than reoperating, and that is to block off the distal part of the tube, stent open the fenestration widely. And so now we've converted them back to a TCP, now we've converted them back to a caval pulmonary shunt without the burden of a second operation. And we're usually able to wean off ECMO then and reassess. So in summary, what are the key points? You've got to preoperative, very good evaluation, optimization, and it's all about selection. That's how you avoid early failure and will influence long-term failure. You have to have a very good surveillance program. There's no point waiting for symptoms to develop. That's usually too late, particularly in the Fontan situation, such as ascites or PLE. You've got to optimize and treat proactively. Optimize all your pathways, interventional cardiology, and optimize your intense medical therapy. Thank you very much.
Thank you, Tim. Thanks for this clear overview of the problems we are facing with. Well, let's move on to the next talk. Well, it's also a pleasure as well to introduce the next speaker is Fabrizio De Rita. He's a colleague of mine. He is a congenital cardiac surgeon, the